Good afternoon, everybody. Welcome to our webinar. I am Callie Rockwell from Burrows Consulting, and I'm just going to I'm not doing anything. I'm just introducing our guest speakers, Colleen and Lori, and they're going to give you more in-depth information about themselves. But we want to thank you for being here today. We're still admitting some people in from the waiting room. So as you join, welcome. And if you have any questions throughout the webinar, please put them in the chat and then remain on mute. Please do not unmute yourselves. Put any questions in the chat and we will get to them at the end or post webinar through email. But thank you so much for coming, and I will turn it over to WeCo Health.
Hi, everyone, and thank you for joining us. I know it's a hectic time of year, so we really appreciate your attendance. I'm Colleen DiClaudio, co-founder and CEO of WeCo Health. I spent the first decade of my career inside two health centers. That's where I realized it's not just about clinical care. They're doing so much more work behind the scenes every day. I saw how programs like 340B keep care going, not just financially, but in real, meaningful way for patients. That experience has shaped everything I've done since. It's why I've built companies focused on helping health centers thrive, and why I care so much about making this work sustainable. I went on to build a 340B tech company named 340 Basics. Today, it's known as Nuvum, which became one of the largest vendors in the space, supporting hundreds of health centers across the country. Outside of work, I serve on two nonprofit boards, both of which care for underserved populations. And now I'm excited to introduce Lori.
Hi, my name's Lori Stevens. I'm a nurse by training. I've been in healthcare for over 30 years. I've worked in a variety of spaces. I've worked at academic health centers, large private physicians organizations, and just recently community health center, which is where I had my eyes opened to the struggles of community health centers and how, they toil away and try to provide as much care as they can for patients, and it's challenging. And so when Colleen invited me to help her on this journey, I was more than enthusiastic to join. So yeah, that's us.
Well, and before we get started, I just want to take a brief minute and I'll tell you a little bit about WeCo and why we care so much about this. As Lori and I both mentioned, we've spent years both working inside health centers, really in the weeds with clinical and admin teams, seeing what works between visits. WeCo provides a fully outsourced care management service. We take the burden off your clinical teams. We integrate into your systems and provide the care as an extension of your organization. We didn't build WeCo to be just another tech vendor. We built it to make care management actually work and to be a partner for your team, for your patients, and then hopefully for your sustainability. So next slide, what we're going to cover today. We're going to talk about what we're seeing in the market now related to care management, the shifts happening around care delivery, talk about reimbursement, some patient expectations around these models, and what this all means for capacity and sustainability. Before we dive in, I'm going to just list three things that I hope you leave here with today from participating and sharing this time with us. First, care doesn't stop at the visit. This isn't bonus care. It should be a backbone. It can drive improved outcomes, keep your team sane, and add sustainable and potentially new revenue streams. Second, you don't have to do this alone. There are proven models out there. You can build it internally by yourselves, or you can work with a partner. Either way, it's possible to make this work even if you're a small organization. And last, this isn't just about billing CPT codes. When done right, care management, it builds trust, it keeps patients engaged, and it improves outcomes that last your teams, that lets them focus on what matters most. So let's get started. And next slide, we'll talk about why this matters now. What's the big picture? And honestly, all these things that I'm going to talk about are your reality and what you experience probably on a daily basis. But 60% of adults have at least one chronic condition. Almost half have two or more. This is including conditions such as diabetes, hypertension, COPD, and depression. These conditions aren't once a year issues. They require regular, structured, between visit support. Also, we're facing a projected shortfall of 124,000 physicians by the year 24. And that shortage, as you probably already seeing, is showing up in primary care, especially in rural and underserved communities. And demand is rising. In less than a decade, 1 in 5 Americans will be over 65. That means more chronic disease, more medications, and more needed coordination. So you're all doing really incredible work, but without new ways to stay connected between visits with patients, these gaps, they'll just continue to widen. So that's where care management comes into play and why we think this conversation is so important. Next slide. So in the next slide, I'm going to talk about how and why these programs were started, but I thought I would do my best now to explain in a practical way, not from a policy manual, what care management means and what it actually looks like day to day. So, as with all federal programs, there are requirements that must be met in order to bill and remain compliant, which I'm sure most of you are used to. Chronic care management is for patients with two or more chronic conditions. It's built all around regular check-ins, care plans that are created with the patients, and care coordination. All of that happens where the patient needs it, from the comforts of wherever they live, outside the four walls of your organization. To bill for it, you need at least 20 minutes a month of a documented non-face-to-face care visit. Remote patient monitoring, this brings in biometric data like blood pressure, weight, or glucose monitoring through connected devices. That's cellular or Bluetooth devices, but these data must be submitted electronically. They cannot be entered manually by anyone. And the key here is to obtain a minimum number of required days in a month. The coordinator will track the time spent coaching the patient, just like CCM, but there's a separate setup and ongoing reimbursement for monitoring and the clinical review. These two programs, they work really well together. CCM gives you structure and RPM gives you real-time data. And together they keep patients engaged and on track. And then there's behavioral health integration, which is designed for patients with behavioral health needs, one minor condition that requires a little extra support. As you can imagine, patients with multiple chronic conditions, a little extra check-in for some behavioral health challenge that they're dealing with can go a long way. So this covers, it also covers assessments, the PHQ-9 assessments and others, covers coordination, and again, monthly check-ins. And it's documented and billed once a month. Now, here's the part that trips a lot of people up. All of these are reimbursable, but only if you're tracking the time and documenting them correctly. That's where a lot of revenue can possibly get left on the table. So if done well and implemented at scale, over time, these programs, they could improve your UDS measures, HEDIS, and any other value-based care arrangements if they're at play within your organization. You will have hopefully less missed visits and real engagement with your patients. And of course, most importantly, which Lori will show you through some real stories. Patients truly love these services. So next slide. Next slide. It didn't switch for me, Callie.
Potentially there's a, yeah, that's, I'm sorry about that. I don't
That's
know
okay.
why it didn't go. Okay.
There you go.
There we go. So now we're going to zoom out for a minute and I'll discuss how these programs got started. They've been around for over a decade. Back in 2015, CMS rolled out chronic care management, but FQHCs and rural health centers were left out. Private practices and other specialties and providers could bill for care management services, but for health centers, it was considered part of their PPS rate. So even if you were doing the work, there was no additional payment. Then in 2020, COVID happened. I'm sure you remember, and it really accelerated the growth and need for virtual care. Rates, utilization, and programs increased. And then finally, in 2022, CMS introduced a bundled code that let the FQHCs and rural health centers bill separately for care management, but it combined CCM, excuse me, it combined CCM, RPM, and BHI. That was a turning point. That was a turning point for health centers and rural health centers. So it meant that they could finally participate and then generate revenue to help sponsor and support the work that was being done. And then this year in 2025, CMS took it a step further. They unbundled these codes. So no longer just one code for all the services. They allow CHCs and RHCs to bill for the codes themselves, just like all the other providers, which again, it allows for more flexibility and better alignment with the care teams to show all the work that's getting done every day. So it's been a journey over a decade, but it's all led to this moment now where care management, it's not only possible at scale for health centers, it's almost expected. CMS has been rolling out new programs. This year they rolled out APCM, which is an advanced primary care model, and they just announced a new model called Access, which will launch in 2026. It's brand new. It's a 10-year initiative that will focus on supporting chronic condition management and then rewards for outcomes, not just activity. We'll have some more webinars in the future to cover this as we learn more. But in summary, just to make it clear that these programs have been sponsored for a long time by CMS. It's predominantly been known as a Medicare service, but a lot of Medicare plans across the country and commercial plans are reimbursing for these services as well. So now I'm going to hand it over to Lori so she can dig in and explain how these services are actually offered.
Thanks, Colleen. Next slide. So it is clear that virtual care is no longer an option. COVID and its aftermath has changed the landscape on this, forever, basically. Prior to COVID, there was a lot of ambivalence about virtual care and whether it should be used, shouldn't be used, how effective could it be. But definitely COVID proved to us that you can do it and you can do it well. And so we did find out that it's possible to deliver high quality care remotely. And with the reimbursements improving, like Colleen says, CHCs, it's time to get in the game and don't leave, any of that money on the table. Next slide. So the power of in-between visit care, and there's some healthy skepticism around what can someone accomplish during a 20-minute telephone call, in between provider visits. But I can tell you that a lot can be accomplished. The frequency in that it's every month reinforces a lot of the messages that we try to teach patients around their, management of their chronic care conditions. One of the things that we do is intervene before the condition leads to an ED or hospitalization. Medication management is a big part of that. So do they have their prescriptions? Do they understand their prescriptions, and are they taking them properly? Also, when you get them on the phone, you discover symptoms that they haven't reported to anyone. And so being able to then take them and bring them into the office to be seen is key. It helps avoid ED and hospitalizations. Other things that we do to support this practice in between is making appointments for patients, refills, practicing. A lot of times patients will ask us to practice doing their finger stick during the visit. So we do a lot of reinforcement and re-engagement. Next slide. So what patients value most, like us, patients want to be seen, heard, and understood. Check-ins between the office visits establish trust. Consistent messaging, like I mentioned, month over month, reinforces the education that they've gotten probably ever since they were diagnosed with their conditions. And it does lead to true understanding. Just the repetition really helps a lot. And then reminders. We remind our patients of when they're due for their office visits and other, important screening things that they need to do. And as they're able to meet those demands, they start to feel motivated and that they can, they're starting to feel some ownership of their care. And that's really awesome to watch. So I will tell you that, the patients, like Colleen said, they do appreciate the call. A lot of times, these folks are lonely, and it helps for a kind person to be calling them and helping them with the things that they need help with. Next slide. And so key features. So if you're considering scaling your virtual care program, there are a few things that I think you should be under your consideration. First of all, will it integrate with your current workflows? If you're starting to, if an organization, you have to redo your workflows, that's just too hard, basically. So work with a partner that will work well with your existing clinical workflows. And then work with a partner that has a multidisciplinary team. So, the difference, all those programs require a little bit of different expertise around them. And so, the having care managers, care coordinators, behavioral health people, and, even pharmacy can help enhance these programs. And so the patients that are in your panels have access to every program that is available to them should they need it. And the other piece is RPM is, measuring people's blood pressure and other things at home is a big part of what we do now. And having a partner that is efficient in managing the equipment that is needed. This can be a significant burden for health centers when they're trying to get started on this. And so having a partner that you're working with that has this dialed in really saves a lot of headaches. Next slide. So virtual care can be outsourced without losing control. And how does that work? So a few key considerations for organizations that are considering outsourcing. You set the clinical protocols, and then the organization executes on the protocols, require transparency on all patient interactions. It's important, how often the interactions are, if you want to even have transcripts of the interactions. Those are helpful if there are any questions after the delivery of care. And then having a partner that has a robust IT system, part of what Colleen was talking about relative to the compliance piece. So for clinical and billing compliance, it's important to be really dialed in on the number of minutes that you are using while you're taking when you're working with the patients. Next slide. So what success looks like. These are the fun things. So I will tell you that I know I've said before that the in-between visits are powerful, but these are 3 examples I think will show, and they've actually literally happened within the last week and a half. So these are current stories. So last week, I was working with a gentleman who had been, when I was reviewing his chart, they were a bunch of labels of noncompliance. And usually noncompliance is sort of a myth because, we don't have time when they're in the office to actually get to the bottom of every single thing that's that they're dealing with. And so this is an opportunity for us. So my patient had obesity, hypertension, hyperlipidemia, and type 2 diabetes. And so he had been placed on Ozempic, 8 to 12 months ago, and he wasn't having any improvement in anything, not his weight and not his the labs for his type 2 diabetes. And so we had a long conversation around, what was happening. And after a lot of discussion, he realized, and we both understood, that Ozempic is going to help him with all of his conditions, and that is what we're going to focus on. And so he was having a hard time figuring out when he could manage to take it because he has a very active life. He still works. He coaches little league football, and so he has a lot going on. But when we discussed it, the one thing he does every single week, like a religion, is sit down for Sunday football. And so we said for during the football season, before he turns on the TV on Sunday, he's going to take his Ozempic. And so I found out that he did take it last Sunday, and so that's going to make a big difference for this patient, and I'm going to follow up with him. And he said, "I'm so glad you called me." So that's a good feeling on both sides. Also focusing on the home environment, some things that you can say when the patients are in the clinic, the patients don't really have the time to actually think through, how does this work for me? And so especially on the initial calls, we talk about all the things that their providers are asking them to focus on as far as their self-management, what they do and what they can't do. And part of that building the trust with the patient is that they actually tell you what's going on. And so I was talking to this woman who, was also having some difficulty with her self-management. And it turned out that her daughter calls her for emergency childcare frequently. And when she goes over there, she thinks it's only for a little while, but ends up being like the whole day or overnight. And so, she doesn't do any of her healthcare when she was doing that. So we created a plan that she was going to create a go bag. Just assume she's going to be away for 24 hours, put everything in the go bag and take it with her when she's called. And so, that's also helping someone understand that their care plan moves with them wherever they are. And then finally, catching worrisome trends. This happens day after day after day. We check in with someone and they say, I don't have time really to talk to you today because I'm not feeling well. It's like, well, that's why we're calling. What's going on? And recently we had a patient who had the worst headache of her life for 2 days. And we arranged to have her be seen at the PCP's office right away. And, that could have easily been an ED visit and who knows what else. So, these check-ins are meaningful. We have a lot of heart here at WeCo, and, we really pride ourselves in engaging with people and helping them, take care of themselves. Next slide.
Great, thanks, Lori. Now let's take a quick view of the financials and some reimbursement estimates. As Lori mentioned, and as we've covered, we know these models work. Patients are engaged. They like these services. They improve outcomes. CMS and many payers are supporting them and continue to expand on them. And then outcomes, there's a ton of studies and reports that show that these outcomes are really well documented, and that's why we can continue to expand on these. But in regards to just reimbursement for CPT codes, if we give it an illustration of a combined CCM and RPM program with just 100 enrolled patients, we show that this can generate anywhere between $180,000 to $250,000 annually in reimbursements. That's before you consider adding BHI, or any other enhanced services. So, and if you recall earlier, one of the key takeaways I would like you to remember is to realize that care management is more than just CPT codes, right? There is additional soft revenue on top of all of the great clinical outcomes and what it means to the patients. There's additional revenue that doesn't show up in, let's say, a billing report, such as increased face-to-face visits. So they're getting back in to see their providers more regularly. There are much fewer no-shows, and there's better patient retention because somebody's checking in with them monthly to making sure that they're really taking care of their care and actively participating. So I've been in this space a long time, and I know the challenges that providers and health centers have faced, and 2026 will not be short of these challenges and many unknown circumstances that we'll face. So I just want to reiterate how I truly believe that these models work, and we've seen the value that they can bring to organizations and to patients. So this is just a little illustration of what reimbursement and sustainability could look like. So next slide. Yeah, and then to wrap this all up, I hope that you learned today by participating and sitting with us, is that care management it's a powerful tool that it can improve outcomes. It will definitely strengthen patient relationships, and for sure will allow you to grow sustainable revenue if you can scale these programs and do it as clearly and simply outlined on this slide. It can elevate everything that your organization is probably already doing. So next slide. Oh, I think that's it. I think that is it. It's one final takeaway that I hope sticks with you from everything that we covered today. You really don't have to do everything at once, right? But something intentional between visits is better than doing nothing at all. Start where it makes sense and build from there. And we're here if you want to continue the conversation. We'll give you all of our contact information. And thank you again for joining. And I'm going to open it up if there are any questions, Callie.
Yes, and again, if anybody has any questions that they would like to ask, please put them in the chat. And we have one from Chris Spenland. I hope I said your name correctly. It is, what is the upfront investment to get started, including cost, times, and internal lift, and what ongoing resources or expenses should an organization expect once the program is live?
Well, it's a good question, Chris. It depends really how this is set up and structured within an organization, whether the entity is setting it up themselves or if they're outsourcing it. If if they're setting it up themselves, like we've outlined, Lori got into the weeds a little bit about it. You need to make sure that they have the systems in place to support all the tracking and monitoring from a compliance. Like I said, this is a CMS program, and with that, there's requirements and regulations that must be followed. So you have to track the time. You have to make sure that the care plans are there. You have to make sure the patient gives consent to participate. So making sure that you understand all the requirements to bill for these programs. So that's number one. You need to have the system set up and in place. Then you need to have the care coordinators and the outreach and enrollment people that are calling patients, getting them engaged, explaining to the program to them. And then the clinical team, the ones that are spending month over month, keeping them engaged, keeping them on track, and make sure that they're following their care plans. And then lastly, just making sure that everything gets billed, like I said, according to what the regulations are laid out for each CPT code. Now, if you outsource it, depending on the vendor, there shouldn't be any upfront costs. It's easier just to plug and play because they have everything already built and ready to go. So typically you're not paying for anything until you're live and off and running. So yeah. And all those costs can vary depending how big you want to scale it. If you're using an outsourced partner, they can scale it easier. 'Cause they're built for that. So internally, every time you want to grow it, I'm sure you have to add more staff to support the demand. Kelly, any other questions?
Yeah, we have a few that came in during registration. How do we determine which patients are eligible for CCM, RPM, and BHI, and how do we actually find them in our system?
So I can take that one. So there are lots of options. It depends what internal EMR systems that you use, but most of them allow you um, to track patients based on a lot of different things, whether it's high blood pressure, patients with 2 or more chronic diseases, which is required for CCM. And usually you would get a report out from your EMR system, and then you would hand that over to the vendor, and they would reach out to the patients, explain the program, and sign them up if they're interested.
All right. We also have, if we don't have the staff capacity right now, can we still implement care management programs or should we wait until we do?
Well, again, it depends on how you are going to manage this. If you don't have the staff on hand and you want to get started, I would say the quickest way to do that is to outsource it so that you can immediately start providing the care to your patients. That's probably the easiest way to get started. If you want to build it internally, you can start doing an assessment, see what's needed, see how many patients that you have, like Lori said, in your panel, and then go from there. Start looking at the capacity and the load that will require you to hire the staff to provide that service. And then you can get started once you realize what that looks like. Anything else, Callie?
Yeah, in the chat they did ask, are you going to send us anything for a breakdown of costs? Christy Morris.
Oh, yeah, we can reach out if you, we'll send you all of our contact information. We'll also be sending the slides to you. And then we can set up a call or we can send information directly related to costs if you want to learn more about WeCo for sure.
Yeah, that's great. We had, how do these programs actually show up in our reimbursement and do we bill directly or does a vendor do that?
Oh yeah, so these services are built under the FQHC or the organization that's actually providing the services. If you outsource it to a vendor, they're billed incident to. So the outsource vendor will provide you with a utilization report down to the patient so that you can go in, take that information, and just bill it directly through your system. So if you do it yourself, you create the encounter, you document everything that needs to be documented, and you bill accordingly. And if you're outsourcing it to a vendor, they will provide you with all the information for you to go in, make the encounter, and also bill it.
Yeah. That's great. I also see we do have some questions coming through in the chat. We're going to make note of those. And then we're doing a follow-up after this, or WeCo Health will be doing a follow-up after this. So if anything doesn't get answered now, it will be answered in a follow-up email post the webinar. We have time for about one more question. And the one that we have is, are these programs really sustainable long term, or are we just chasing temporary CMS incentives?
I could take this one.
Okay.
Colleen spoke to this a little bit in that, this is not a fly by night. These programs are here to stay as far as we're concerned. In fact, they're trying to, like Colleen was saying earlier, expand them and add more programs to them. And, it just, makes sense that as our population ages, they have more chronic disease conditions. They're going to need this type of care, regardless of whether it's a program or not a program. Care management is going to be the key moving forward to help manage your patients.
That's great. Well, I want to thank you guys so much for coming, Colleen and Lori. We appreciate everything. Again, there'll be a follow-up email from WeCo Health with the webinar link, with the slides, and please reach out and get in contact with them for any follow-up or any questions. They're a wealth of knowledge. So, yeah, we just want to thank everyone for coming out, and that concludes our webinar. Thank you guys.
Thanks
Thanks,
for having us.
everyone.
Thanks, everybody.
Thank you.